So we have a lot of new effective therapies coming along in CLL, but we also have some older effective therapies like FCR. We know that FCR is particularly effective for the young, fit patients who have the mutated IGHV status. Some of those patients can go 10 years or longer in complete remission, and actually presumably some of those patients may even be cured. The problem is that we have patients with higher risk disease like unmutated IGHV who typically do not get a durable response from FCR alone. And we have a new drug, Ibrutinib, that's very effective for those patients with unmutated IGHV. So the idea for our study was to put these drugs together, Ibrutinib plus FCR, for about 6 months of combination therapy, and then patients continue on Ibrutinib maintenance for at least a couple of years after that. And today we're presenting a poster here at the IWCLL meeting that updates our data from the ASH meeting 2016. And we have now fully accrued the trial at 35 patients, and we're seeing very nice efficacy data. So about 40% or so of our patients are getting into a complete remission with MRD negativity, that's minimal residual disease negativity in the bone marrow, which compares quite favorably to prior studies of FCR alone. And we're seeing excellent rates of MRD negativity even in the patients with the unmutated IGHV. The follow-up is still relatively short, a little over 1.5 years or so, so it's too early to know the progression-free survival benefits. But we do know that the rate of MRD negativity, particularly in the bone marrow, correlates very well with progression-free and overall survival. The other thing that's been striking about our study is we have about an 80% or more rate of bone marrow MRD negativity on its own. Some of these patients just have very small residual lymph nodes. So some of these patients may also have very durable responses, even if they don't technically meet the criteria for CR yet. So our standard of care is to use growth factor and antimicrobial prophylaxis as a standard measure. It's mandatory in the study for all patients. We do think this is actually quite important because we've seen much lower rates of neutropenia and febrile neutropenia on our study compared to prior studies of FCR alone. So we think this is the safest way to administer this regimen, and we encourage people, if they in the future are going to use this, to use growth factor support mandatory. So at this meeting, we're also presenting updated data on our study of duvelisib plus FCR. Duvelisib is a delta gamma PI3 kinase inhibitor that's in development. It's not yet FDA approved in CLL, but it's also a very active drug and targets the B-cell receptor pathway. We've been running this study in parallel with the Ibrutinib FCR study, and also seeing very nice results with duvelisib, similar rates of complete remission with bone marrow MRD negativity, a little bit more in the way of toxicities in the frontline setting. We know with PI3 kinase inhibitors that there are risks of these immune-mediated toxicities, which we have seen in our study. On the order of about 1/4 of our patients have had grade 3 or 4 transaminitis. But this is actually lower rates than what has been seen in other studies with, for example, idelalisib and ofatumumab, where the rates approached 50%. So one hypothesis is that the chemotherapy component of our regimen may be dampening the immune-mediated toxicities. So I think this poster is also showing promising results for duvelisib FCR, and it may be a nice option for patients perhaps who have risk factors for toxicity from Ibrutinib, for example, patients perhaps who have atrial fibrillation or bleeding risks who want this kind of combination approach may benefit from a duvelisib FCR approach if our results hold up. So the populations on both studies are quite similar, tend to be a mix of mutated and unmutated IGHV. We have some patients with deletion 17p included who have all responded as well.